morning, everyone. My name is Dr. Pooja Raj, and my topic for today is radiation injury. And my moderator is Dr. Jamshed Naik. So, moving on with the case scenario test. Dr. Shrishti, can you please read this for us? Can you give us some provisional diagnosis? Okay, next, Dr. Sheila. Okay, soft tissue infection in the ear. And next, Dr. Abhiraj. Reaction can occur. Basically, see, patient has redness and itching, so what and blisters. So what can you suspect? Patient can have a chemical injury or burn injury, or it can be an insect bite. But this patient patient denied that there is no history of thermal or chemical burn or insect bite. And over the course of 10 days, the lesion has ulcerated and undergone necrosis. And a similar history was given by his wife, but the lesion appeared days after the one his husband had. Moving on to our presentation. So why do we need to learn about this topic? Because there are instances in the past where the radiation exposure lead to many casualties. One such incident was the Chernobyl incident. It happened in 1986 in April 25th, where a failed experiment has led to chain reaction in the nuclear core, which has led to multiple explosions, which has led to this exposure of a large amount of radioactive elements into the air, and has affected many people living in the Chernobyl. And there was increased risk of different types of cancer among the living people and the generations to come. Eventually, an exclusion area was created around this nuclear power plant, and nobody was allowed to go inhabit this area. Then this lecture will be divided into various topics like types of radiation. We'll be covering the types of exposure, mechanism of chemical injuries, the main topic which is the acute radiation injuries, the local radiation injuries, and finally the management of radiation injuries. Moving on to what is radiation. Basically, radiation is the energy which is emitted by the unstable atoms which are undergoing this radiation decay. And this radiation, they travel in the form of energy waves. And moving on to the types of radiation exposure. The radiation exposure either can be a contamination or can be an exposure. Contamination is basically coming in direct contact with the radioactive material. The contamination can be either external or it can be internal. So external contamination is basically contamination of the skin or the clothes of the person with the radioactive material. Internal contamination is when the patient has inhaled or ingested the radioactive elements. We do have a video which shows all of these. Then there is irradiation. Irradiation is basically indirect effects. Basically, the patient is exposed to the energy waves which are given off by the radioactive elements. This video shows the difference between irradiation and internal and contamination. The contamination can be this external or can be internal via inhalation or via ingestion. Irradiation is because of the energy, the patient is exposed to the energy wave. Moving on to the electromagnetic spectrum. This electromagnetic spectrum is divided into non-ionizing and ionizing radiation. As we move from left to right, the wavelength keep on decreasing and the frequency keep on increasing. As the frequency of the waves increase and as the wavelength of the frequency of the wave decreases, the energy of the particle increases. so thereby differentiating the ionizing and the non-ionizing radiation. The non-ionizing radiations basically differ from ionizing radiation because ionizing radiation, as the name says, they can cause ionization. Basically, they cause the emission of the electron from the atom, making them highly reactive in nature and causing DNA damages. The examples of ionizing radiations are X-rays, gamma rays, alpha rays, and beta particles. Non-ionizing radiation examples are radio waves, microwaves, and infrared rays. Then moving on to the types of ionizing radiation. The alpha, beta, and gamma, they are produced by the unstable atom which are undergoing this radioactive decay. And there are X-rays and there are neutrons. Alpha rays, basically, they are positive particles. They are made up of 2 protons and 2 neutrons. Since they are very heavy in nature, so they are unable to travel long distances. So therefore, they are unable to penetrate the skin, and they can be stopped even from a piece of paper. Then on the other hand, we have beta particles, which are negatively charged and very light in nature, since they are made up of only electrons. The low energy beta particles can be stopped with a layer of clothing, and high energy beta particles can be stopped using a half an inch sheet of aluminum. Moving on to the X-rays and gamma rays. X-rays and gamma rays are pure energy since they do not have any mass and they pass completely through the human body. They are basically the same particles, but they originate from different parts of the atom. The gamma rays, they originate from the nucleus of the atom, whereas the X-rays, they originate outside the nucleus of the atom. And the X-rays have low energy than the gamma rays. And since they are highly penetrating in nature, several sheets of lead and concrete are required to stop them. Then there is something known as neutrons, which are neutral in nature and they are produced during the nuclear fission and they have the highest penetrating power. Moving on to the penetrating abilities of the ionizing particles. We have already discussed as the alpha particles, they are heavier in nature, they can be stopped using a piece of paper and cannot penetrate even the skin. Beta particles, on the other hand, they can pass through the skin, half an inch of the skin, and can be stopped using this half an inch of aluminum. Okay. And then there is gamma and X-ray, which have high penetrating power, and sheets of concrete and sheets of lead are required to stop them. Then followed by neutrons, which require sheets of concrete to stop them. Moving on to the mechanism of radiation injury. The first theory is the target cell theory, which is the direct cytocidal effect caused by radiation. So basically, it is divided into 2 models, the H-type model and the F-type model. The H-type model says that the tissues made up of cells which are divided into 3 compartments, which are the stem cell compartment, proliferating cell compartment, and the mature cell compartment. The stem cells are made up of cells which have unlimited dividing capability. They do not have a tissue-specific function and they can renew themselves. Whereas the cells which are formed by the stem cells, they go into the differentiating cell compartment, where these cells are in this process of differentiation and they are a process of attaining a specific function. Then there is this mature cell compartment, which is made up of permanent cells. They have lost their ability to differentiate and to divide. So basically, whenever a patient is exposed to a radiation, since the stem cells, they have high mitotic index and high turnover ratio, so these are the cells which are most sensitive to radiation and they undergo DNA damage and damage of the cell. Since the mature cells, they do not have this dividing capability, they are the least sensitive to radiation. After exposure to a high amount of or a large dose of radiation, these stem cells are destroyed and they are unable to form proliferating cells. And once the lifespan of these mature cells, they are over, so then is the time when the patient has clinical signs and symptoms, since because of cytopenia or the lack of cells which are used or which are required for the normal functioning of the body. Moving on to the F-type model. This model says that the cells are not divided into compartments. Rather, these cells are the tissues made up of cells which are identical in nature and they have a specific tissue-like function and they all have a renewable capacity. And once they are exposed to radiation, these cells, the residual cells, they undergo overwhelming growth overwhelming this division leading to a large number of cell production, which is basically causing cancer. We have a video which shows all of these mechanisms. This is the F model type in which the radiation causes injury and the residual cells are able to, they cause overwhelming generation of cells. And this is basically showing that H model type of this injury where the cells are completely destroyed, unable to form the proliferating cells and leading to cytopenia, and death is caused due to this lack of cells which are required for normal function of the body. And moving on to the multicellular target cell theory. Basically, it is the indirect effect of the radiation. These radiation they causes this DNA damage and damage to the cell, which lead to formation of a lot of free radicals. This free radical in turn causes damage to these free radicals in turn they causes further damage to the cells. Moving on to the main topic, which is the clinical signs and symptoms which appear on exposure to radiation. The first one is the acute radiation syndrome, also known as radiation toxicity or radiation sickness. The acute radiation syndrome is basically constellation of signs and symptoms which occur due to acute exposure of the whole body with a large dose of external penetrating radiation, which is usually more than 0.7 grays. The acute radiation syndrome, it is further divided into sub-syndromes like Hematopoietic Syndrome, which occur at a dose rate of 2 to 10 grays, and then Gastrointestinal Syndrome, which occurs at a dose of 6 to 15 grays. And finally, there is Neurovascular Syndrome, which occurs at a radiation dose of more than 20 grays. Moving on to the phases of these acute radiation syndrome. It is divided into this 4 stages. The prodromal stage, which is basically the initial phase of the acute illness, which appears within 1 to 2 days after exposure, followed by the latent phase, in which the patient is minimally symptomatic or asymptomatic, but the laboratory findings are abnormal, and followed by the manifest illness phase, which is the main phase of illness where there is specific signs and symptoms of each syndrome which appear depending on the dose. Finally, there is recovery or death. The point to be noted here is that it is dose dependent. As if the patient is exposed to larger doses, the onset of these syndrome will be earlier, and this period of latent phase will be shorter. Moving on to the symptoms which appear in prodromal phase, basically it appears within the 0 to 2 days. Within 2 days, the patient has nausea, vomiting, diarrhea, headache, dizziness, and lethargy, followed by a latent phase which appears from day 2 to day 20. Patient can be mildly symptomatic or can be asymptomatic, followed by the manifest illness phase which occurs at the day of 21 to 60. Where there is specific signs and symptoms like infection, bleeding, diarrhea, and moving on to hematopoietic syndrome. The hematopoietic syndrome, it occurs at a dose of 2 to 10 grays. Basically, the radiation has caused the death of the stem cells, and they are unable to the stem cells are unable to proliferate. And now, when the mature cells they die after their lifespan, this leads to cytopenia and the clinical signs and symptoms. The patient dies because of this lymphopenia, neutropenia. The patient dies of infection and hemorrhage and sepsis. Moving on to the grades of hematopoietic syndrome. There are 4 grades from H1 to H4. All the patients with more than H2 grade should be hospitalized, and from H1 to H3, the signs and symptoms and the injuries are reversible in nature. Whereas the H4 is irreversible in nature and the patient will die unless the patient is given the hematopoietic stem cell transplantation. Moving on to the various degrees or grades of hematopoietic toxicity. Grade 0 is basically normal. Grade 1 is basically when grade 1 is basically at this time the absolute lymphocyte count will be normal, or at at the lower end of the normal range, which is more than equal to 1500, and the absolute neutrophil count will be more than 2000, and the platelet count will also be more than 1 lakh. The patient will be having this normal hemoglobin level with patient will be asymptomatic or will have this mild symptoms like petechiae or bruising. In grade 2, the absolute lymphocyte count comes down to 1000 to 1500, and the absolute neutrophil count it comes down to 1000 to 200, and the platelet count lies between 50,000 to 1 lakh. The patient will have less than 10% decrease in hemoglobin and mild blood loss. In grade 3, the absolute lymphocyte count will lie in the range of, and absolute neutrophil count will lie in the range of 500 to 1000, and the platelet count will lie in the range of 20,000 to 50,000, and there will be gross bleeding will be present with 10 to 20% decrease in hemoglobin. In grade 4, there will be the absolute lymphocyte count and neutrophil count will be less than 500 with platelet count of less than 20,000. There will be spontaneous bleeding and there will be more than 20% decrease in the hemoglobin. Moving on to the gastrointestinal syndrome. The gastrointestinal syndrome, it occurs at an exposure dose of 6 to 15 grams. The clinical signs and symptoms are due to lack of replacement of the mucosal cells of the villi because of the destruction of the stem cells present in the crypts of intestine. So between the patient, because of the loss of all these cells, the patient will have profuse diarrhea, and because of diarrhea, patient will have dehydration and electrolyte loss. Because of ongoing hematopoietic syndrome, the patient will also have this incidence of bleeding. And since there is loss of this mucosal barrier, there will be easy entry of this bacteria into the bloodstream, and the patient will finally die of sepsis and bleeding and dehydration and multi-organ system failure. Moving on to the different grades or degrees of gastrointestinal system. Basically, with each degree, the symptoms get worse. From 2 to 3 stool, it may proceed to more than 10 times the number of stools, and the consistency will continuously deteriorate with the increase in the exposure of dosage, and the incidence of GI bleed will increase with persistent large amount of bleeding will be seen in degree 4, and the severity and intensity of the abdominal pain will increase with increase in grade. Moving on to the neurovascular syndrome. Basically, this patient is having the exposure dose of more than 20 grams. This patient has a very poor prognosis because there is this increase in intracranial pressure, and the death is inevitable in these patients. And the patient initially complain of this headache, nausea, vomiting, which are signs of this increased intracranial pressure. Finally, there will be loss of consciousness, and episodes of seizures or neurological deficits can occur, and ultimately leading to death. Then moving on to this various degrees of cerebrovascular symptoms. Basically, the symptoms will get as the degree increases, and it depends upon the amount of dose the patient has been exposed to. And at the degree 4 is basically given palliative treatment as the death is inevitable in these patients. Moving on to the localized radiation injury or the cutaneous radiation injury. The injuries to the skin and the cutaneous radiation injury is basically injuries to the skin and the underlying tissue from acute exposure to a large external dose of irradiation. So all cutaneous radiation syndrome will be all cutaneous radiation syndrome will be a part of acute radiation syndrome, but all radiation syndrome will not be a part of cutaneous radiation syndrome. Basically, they occur at a dose of more than or equal to 2 grays. Stages of cutaneous radiation injury. It is basically divided into early arrhythmia phase, followed by a latent phase, followed by a second wave of arrhythmia, and third wave and fourth wave depending upon the exposure dose and late effects, and finally recovery or death. The prodromal stage, it appears within hours of exposure. It can appear within hours of exposure if the exposure dosage is very high, or it may appear 1 to 2 days after exposure. Basically, it is characterized by early arrhythmia, which is the first wave of arrhythmia. There will be intense itching and arrhythmia and heat sensation over the affected area. And this can be confused with the patient having a thermal injury or a burn injury or an insect bite. Then moving on to the latent phase, which appear after 1 to 2 days after exposure. The patient is asymptomatic in this phase, and basically the patient is having this abnormal laboratory findings with lymphopenia and neutropenia. Moving on to this manifest illness phase, which is the main illness phase, which appear days to weeks after exposure. In this phase, there is second wave of arrhythmia is there. There will be redness, increased heat sensation, blistering will be there, increased pigmentation, and with increased severity of the larger the dose, the more the symptoms will be there. With dry desquamation will be there, ulceration and necrosis will be there. This is a video which shows the various stages of acute cutaneous radiation injury. There will be intense itching, redness, followed by this second wave of arrhythmia, followed by necrosis and ulceration. Then, every cutaneous radiation syndrome will not be consist of third wave of arrhythmia and late effect. It depends upon the radiation dose. More the radiation dose, it will have more the waves of arrhythmia. The third wave of arrhythmia, it appears 10 to 16 weeks after exposure. Late effects appear months to years after exposure. In late effects, there will be atrophy of the skin. There will be fibrosis and keratosis of the skin. And eventually, in subsequent years, there will be risk of cancer will be there. Recovery will take place after months or years after the exposure. This is a Peruvian patient who accidentally kept a radioactive element in his right pocket. And on day 3rd, he developed this redness and intense itching and blister over his right posterior aspect of the thigh. And he went to a hospital and he was diagnosed with the insect bite. But later on, within 10 days, this lesion has ulcerated and become into a necrosis has followed. And later on, it was seen that this radioactive element was recovered from his pocket by the authorities, and this patient was shifted to the Lima hospital, where this patient had undergone this right leg amputation. Subsequently, his wife also had this lesion over the buttock area. Accidentally, she sat over this patient's pant, and she was exposed to this radioactive element. It had initially within this 26 days, it has developed into a dry desquamation, and within 2 years there was this moist desquamation with the ulceration and necrosis. Then various degrees of cutaneous with acute cutaneous radiation injury. Basically, the arrhythmia, the body surface area will increase with every degree. In cases of degree 1, there will be transient early arrhythmia which will recover very quickly. In cases of degree 2, there will be less than 10% of the body surface area will be involved. In degree 3, there will be 10 to 40% of the body surface area will be involved. And in degree 4, severe more than 40% of the body surface area will be involved. And the symptoms will increase in degree, with severe pain in degree 3 and 4. And there will be no blister formation in degree 1, and there will be no hemorrhage, blister formation, ulceration or necrosis in degree 1. In the necrosis will start from this degree 3, which will involve the subcutaneous tissue, and in degree 4, it will involve the underlying muscle and the bone. Moving on to diagnosis. So always consider this radiation injury, acute radiation syndrome as a part of differential diagnosis. Is the patient present to you with a burn-like skin injury with no history of chemical or thermal injury? And basically this arrhythmia is cyclical in nature. If he gives a history that this arrhythmia appears after few days, then you should think about radiation injury. Also, there will be epilation, which is the loss of hair follicles. and there will be increased tendency of weak. Possibly there will be signs and symptoms of ARS also. Moving on to the initial treatment. The localized injury should be treated symptomatically. If the patient has combined injuries like fractures and trauma, this patient should undergo, and if he present within 48 hours, this patient should undergo surgical stabilization. But if the patient present after 48 hours, the surgical intervention should be delayed as until the hematopoietic recovery is there. A baseline of CBC and differential count should be taken at the time of presentation and should be repeated after every 2 to 6 hours to see for neutropenia and lymphopenia. Also, since it is cyclical in nature, these cutaneous injuries should be recorded, photographed, and should be kept for future reference. The treatment, it comprises of prevention of infection using prophylactic antibiotics, anti-inflammatory, and painkillers and psychological support. Moving on to treatment by stages. In prodromal stage, we should use topical anti-inflammatory, antihistamine. In latent stage, we should continue with the anti-inflammatory medication and this should start with proteolysis inhibitor. And followed by, in manifestation phase, since this phase is very prone to infection, repeated swabs should be taken from the areas and prophylactically antibiotics should be started along with the anti-inflammatory. Late effects require pain management and medication which will stimulate vascularization and which will decrease fibrosis. Eventually, the patient will need reconstructive surgeries, plastic surgeries, if there is excessive fibrosis and deformity of the limb. Moving on to the management. The basic principle of radiation safety. There are basically three principles of radiation safety. Firstly, to maximize the distance from the source. Secondly, to minimize the time of exposure. And thirdly, to shield from the exposure. Moving on to dosimeters. Dosimeters are basically instruments which are used to measure the exposure of ionizing radiation. There are various kinds of dosimeters, the film badges, the TLD. There are various kinds of dosimeters are available, like film badges, TLD, ionization chamber. Film badges are basically X-ray films which are wrapped in papers and then mounted on the plastic and worn by the medical personnel. Basically, the X-ray films contain this silver and bromide. When this silver is exposed to radiation, they are reduced from Ag plus to Ag ions, which will lead to blackening of this film, which are then later on detected and determined for exposure to radiation. Then there is this thermoluminescent devices. Basically, these devices are able, on the exposure of radiation, they absorb this radiation and these radiation they stay in a metastable state. And later on, they release these energy in the form of heat radiation, which are detected and then determined for radiation exposure. Then moving on to this Brigger counter, also known as Brigger-Mueller meter or the pancake meter. Basically, these are the most common dosimeter which are used because they are handheld, highly portable, and relatively cheaper in nature. These meters are made up of Brigger-Mueller tube and this displaying electronics. This Brigger-Mueller tube, it is filled with inert gases like argon, neon, helium, and when it is exposed to radiation, the electrical power is generated, which passes through these inert gases, which causes generation of detectable pulses, which are determined and displayed on the electronics. These Brigger-Mueller meters are able to detect alpha, beta, and gamma rays more efficiently with the beta rays. Now moving on to triage. So during a mass casualty, we should always opt for very short triage algorithm like salt and starch. With all the algorithm, all these algorithms, the patient are divided into these four categories of immediate, delayed, minimal, and expectant. Immediate patients are those patients who cannot wait even a couple of seconds and need resuscitation immediately. Delayed patients are basically they have injuries, but they are not in this respiratory distress and not there is no major hemorrhage. And this minimal patient, they are basically the ambulatory patient, which can be dealt as outpatient. And then expectant, where the patient are too sick and who likely to die with the available resources. Then after the triage, we further categorize the patient into exposed, into contaminated or irradiated. We all the contaminated patient, if they are if they do not have any life-threatening condition, they are sent to decontamination areas. Then moving on to decontamination. Before decontamination, if the, basically the patient after radiation exposure, if the patient is present within just 1 hour, it means that the radiation exposure is more than 6.5. The patient will present with if the patient present with cerebrovascular symptoms first, then before decontamination procedure, all the first responder, all the medical personnel who are first receiving the patient should be well equipped with this dosimeters and personal protective equipment. Moving on to the whole body external decontamination. There should be an external site made for decontamination. It should be far away from the emergency medicine department. And all the patients who do not have a life-threatening condition should be who has this external contamination should be sent to these patients. The patient should be asked. the medical personnel should perform the whole body radiation survey. And all the radiation exposed area or with contaminated area should be marked with a waterproof marker and should be this drawn on a body diagram. This body diagram should be updated after every decontamination cycle. So moving on to the decontamination process, it should be carried out in a following order. Initially, firstly, the whole body should be decontaminated, followed by the foreign body should be removed, followed by decontamination of the open wound, followed by the orifices, and followed by the localized skin region which are contaminated. Ideally, 2 decontamination cycles should be carried out, and the goal is to decontaminate it with not more than 2 times the background radiation level and update the body diagram after every decontamination cycle. After decontamination, the patient should undergo the second whole body radiation survey. If the external contamination it is in excess to 2 times the background radiation level, then the patient extra this decontamination cycle can be given. No attempt should be made for vigorous decontamination as the loss of intact skin will lead to this deposition, loss of intact skin will lead to internal contamination. Then moving on to what are radioactive sharpness. Basically, these are the foreign metallic radioactive compounds which are embedded onto the skin. These are the sources of internal contamination. So this area should be washed carefully and using a forceps, and we should always use a long surgical instrument to maximize the distance between the operator and the sharpness. And after this decontamination, all the foreign bodies and this along with the instrument, they should be stored in lead container and labeled. After decontamination, the wound should be covered with waterproof dressing to prevent further contamination. Moving on to open wounds. All the open wounds are considered contaminated unless proven otherwise. These open wounds are a source of internal contamination. The surrounding areas of these open wounds should be covered with a waterproof dressing to limit the spread of the radioactivity. All these open wounds should be irrigated with copious amount of saline and water. And after decontamination, these wounds should be dressed with waterproof dressing. Moving on to decontamination of body orifices like ear, nose, and mouth. A moist nasal swab should be used to remove all the contaminants around the nose, and this swab should be sent for radioactivity, for the determination of radioactivity. Then moving on to ear decontamination. Before going for ear decontamination, always see for integrity of this tympanic membrane. If the tympanic membrane is intact, use a syringe to rinse the external auditory canal. And this irrigated fluid should be collected and sent for this detection of radioactivity. Then there is this mouth. The patient should be encouraged to do brushing and gargling frequent times, and this irrigated fluid should be collected and sent for this determination. Moving on to decontamination of eyes. Basically, to rule out that there is no presence of sharpness in the globe, you should do an X-ray of the eye. Then, irrigate the eye with a copious amount of saline and water. Do not irrigate the ruptured lobe. After irrigation, the irrigation should be carried out from outer cancers to inner cancers to prevent the contamination of the nasolacrimal duct. All the samples should be from the irrigation fluid should be collected and should be sent for this determination of radioactivity. Moving on to decontamination of the localization. The whole body radiation survey should be carried out, and the radiation injury site or the contaminated area should be marked with the waterproof mark. And in water deficient environment, in cases of water deficient environment, we gently have to brush the skin to remove the portion of the stratum corneum. This is ideally not preferred because this will lead to this loss of intact skin and lead to internal contamination. In water sufficient areas, the patient should be washed with copious amount of saline and water and with soap and water. moving on to this algorithm, which should be carried out for the management of the patient. Basically, if the patient with radiation injury present to the ED, if the patient, so if the patient with the radiation injury comes to the ED and has a life-threatening problem, if he has a life-threatening problem, then he should be directly sent to the emergency department. But if he doesn't have, then he should be examined for the external contamination. If the patient has external contamination, this patient should be sent to the decontamination area. And the following steps of decontamination should be done as discussed above. And the and if the patient do not have this external contamination or has internal contamination, the patient should be sent directly to the emergency department, where the patient should be assessed for this acute radiation syndrome and localized radiation syndrome. And the the main thing is to get a baseline CBC and this differential count done, and should be repeated after every 2 to 6 hours to see for lymphopenia and neutropenia. So if the number of patients are less, then we can go for we can try the patient according to the degrees of various syndromes we have. All the patients who has a hematopoietic syndrome, which is more than or equal to 2 grade, should be hospitalized. And
the triage tool that you use? What is the radiation triage based on the site input? Plus E. Its E is equal to M by L plus E. So measure the neutrophil site ratio and add E. E is emesis. If it is more than 7, there is no emesis, it is 0. If there is emesis, within 1 to 2 hours, this plus 2 will be to the site B plus E and 3.7. Triage this patient, uptriage this patient, there are chances that they can be good. So just go and read about triage.
all the patient with hematopoietic grade less than or equal to 1 who are ambulatory should be considered to outpatient management. And patient with grade 3, 4 should be hospitalized. Mainly they should get a ICU care. And patient with grade 4 who are having the cerebrovascular syndrome should undergo this palliative care. Moving on to this treatment of hematological toxicity. So based on grades, grade 1, if the patient is having this hematological toxicity which is less than grade 1 without any combined injuries, that the patient is having exposure to less than 3 grades. These patients should be treated as outpatient. And if the patient is having this grade less than 1, less than or equal to 1, but is having combined injuries like trauma, fracture, or the age of the patient is less than 12 or the more than 60, these patients should be hospitalized as the risk of myelosuppression is very high and should be given supportive therapy and cytokine therapy. Moving on to grade 2, in grade 2, the exposure is more than 3 but less than 7. These patients should be hospitalized and should be given aggressive supportive care and hematopoietic cytokine. Then grade 3, grade 4, it is more than, grade 3 it is more than 7 but less than 10. And grade 4 is when the patient is exposed to more than 10 grays of this radiation. And this grade 4s have multi-organ failure and they should be dealt under palliative care. Patients having this grade 3, they are the ideal candidate for hematocytic stem cell transplantation.
Despite weeks of therapy, the patient is not improving. They not improving. And plus, they should not be that giving, for example, back to so when you are very sure that it is you will need a management number one, and your patient is not improving, despite giving weeks of therapy with the glycoside or side like yes, and
Moving on to gastrointestinal syndrome, this patient should be aggressively given food resuscitation and there should be use of prophylactic antibiotics. Since they have high exposure to radiation, they are very prone to infection and antidiarrheals like loperamide should be given. The patient ultimately die of irreversible septic shock. Then moving on to central nervous system. Basically, these patients have very poor prognosis. These patients have very high dose radiation exposure that is mainly more than 20 grays. And the symptoms are basically because of increased intracranial pressure and diffuse cerebral edema. So these patients should be dealt under the palliative care. Then we go for IV antibiotics.
अब जो यहाँ पे देखो आईडीसी गाइडलाइन होती है फॉर एग्जांपल सब समझ मीडिया का किसी भी वहाँ पे पेशेंट बस absolutely to sit down the time of it. And third, when we think that this therapy, the radiation or the chemotherapy, this narrow proliferation trend, 7 days, 7 days, can't prevent these. If a patient is suffering from something like, for example, the absolute effect down here, something less than 100. If patient is in the value, if there is grade 3 or more, like this, or if it is associated with organ injury, like patient is on ventilator, patient is having a plastic injury, patient is having bigger, in that condition, what is meant because that is covers this MRSA as well as Synovial. For example, oxidation, hallucination, or hypertension, with that like the mind. So here dealing with bacteria that are absolutely from the so patient hematopoietic even then cycles that IDC are also
end of the presentation. And the take-home points are basically the acute radiation syndrome and its sub-syndrome, how to triage a patient with radiation injuries, and the steps of decontamination, and finally the management of patients.
Any guidelines I think for like when to use radiograph or how much maximum radiograph we can use, like X-ray and CT are already patients in radiation exposure. Further doing X-ray and CT is going to even worsen the radiation exposure. Like safety
So, if you see what is the exposure of X-ray, it's 3.1 millicycles. If you see it, it's an that it's around 5 million millicycles. Just think it's around 7. स्कैनिंग वगैरह कर रहे होते हैं ना, ठीक है ना, जब CTPA कर रहे हैं क्रोनरी कर रहे हैं is 15 to 16. It is not going to damage or degrade the condition of the patient. So you can go for it. So there are two different types of radiation injuries. One is the deterministic radiation injuries, and second is the stochastic. What is the difference? What she said is deterministic. That pain, pain of pain is hematopoietic. 6 to 10 basic. That's it. Beyond that, beyond 12, can you can have deterministic. That is the much amount of radiation required. What is stochastic? What is the OSHA guideline? Stochastic. Suppose your patient is pregnant, कितना एनर्जी वो फिटस को डायरेक्टली करेगा, guidelines that कि आप ही बोला आपको तो कैंसर ना हो जाए. There is no safe limit for it, but there are guidelines that probably if your patient is receiving this much amount of radiation, he probably he is not going to develop malignancy. Like thyroid malignancy is very common. Leukemia lymphoma is very common. So according to OSHA guidelines, it is 50 millisieverts. Okay. Or for pregnancy, it is 5 millisieverts over a period of 9 months. Anything more than that can produce some effect on the fetus or the individuals. Any question on radiation injuries? Any doubts you have? It is basically based on what is the amount of radiation the patient has experienced. For example, if a patient is exposed to very high dose of radiation, but she's talking about that this is the prodromal phase, then there is a later phase, and then manifest phase, and then there is recovery or death. But these phases are not always sacrosanct. If there is very high exposure, there is prodromal phase, and that prodromal phase can lead to death. That's it. But if it's based on deterministic effect, that this is what to coordinate, then initial patient can have some erythema. Initially some, then there will be latent phase, there is some recovery, and again there is some underlying tissue because I think basal layer of the epidermis they contain they are more affected and when they regenerate some non-native there. So there are multiple pieces that you're getting. I think ऐसा लिखा हुआ नहीं कि कितना दूर होना चाहिए. It should be as far as away from the patient care area. But यहाँ पे कहीं कोई distance का level नहीं किया हुआ है. Okay. What they are saying that you have to create a decon area just around emergency, so that decontamination activity should be done in the other field where actually disaster will happen. But the chances that patient could receive further radiation, because radiation patient can have radiation even after decontamination. So we have to see what is the level of quantity by using diagonal concept, that what is the radiation patient has already having. So if you think that that is more than 2 times the baseline or the surroundings into radiation level, if it is more than 2 times, then you have to be on.
Last question. Suppose you have an announcement, right? We are going to receive radiation, patient with radiation exposure, right? To the emergency department. What will be your steps? Yes. Got the question? You got a receiving call. Got a call from the duty officer that will receive or patient with radiation exposure. What will be your response as a person working in the emergency department?
Activate this facility response will activate the facility response will tell the MD staff that this large amount of patient with active radiation injury are coming, and they should be equipped with all this protective personal protective equipment and dosimeters. And these decontamination areas should be made, which should be made at an external site to the emergency department. And if the patient is in life-threatening condition, the patient should be directly sent inside. And all those patients who do not have life-threatening condition should be sent to the decontamination area.
Any kind of disaster, okay, first you need to confirm the information, right? Whether it is a true one or a falsity, confirm the information. Second is you need to immediately call up the faculty. That I got a call like this, inform your seniors immediately. That what is the HOD. And also follow the disaster plan. Okay, have a protocol, open the protocol book for acute radiation, radiation mass casualty, and follow that. Because the incident command will be of activating the incident command system of paramount importance in any mass casualty, but this is a radiation one, which is not very common. So, once in a blue moon you will see. तो आपको एक वो फॉलो करने की जरूरत है. ठीक है ना. बाकी whatever knowledge we discussed today we made operational by practicing also regularly. Regularly practicing. How you remember? This is a topic which is there is a risk. Yes, there is a theoretical risk all the time. How you can gain expertise in this by doing regular mock drills about regular, following the plan, have a plan, plan. That is very important for also remembering so many things. But it's not a very easy topic. And Pooja, you have done a great job by the presentation. I really appreciate it. Very bright. It is a very bright topic. TCMA is also very important. Explaining radiation to the different kind of light techniques, especially when you do different setting rays, and the diam. There is a lot of room for improvement, the spontaneous improvement is great.
Sir is asking what kind of PPE will you use when you actually there's some patient with radiation injury comes to it. Which one? There is A, B, C, D. So कौन सा करोगे?
Especially it is like shield and ID.
So the recommendation is you can use C or D type of PPE even in the fields, unless until there is some chemical or some other biological warfare also being used. So for all radiation injuries, unless you are a first provider where you have to go to the site and do some decontamination, you have to extricate the patient. And decon areas, which is from the center, few kilometers or few meters away from that, you can use COT type of PPE. So you can use face shield or N95 mask. Even if it is not available, you can use the surgical mask. Use normal coveralls, boots with shoe covers, and you can use face. If you're using face shield, then there is no need to use covers. And they are saying that at least gloves should be doubled, and the inner glove should be safe, should be just to fix it. And outer gloves can be removed after examining every patient.